Then it's time to put the data together. That was a meta-analysis that was published, putting the outcomes trial of AHF and Ironman together. And as we can see, consistent, significant improvement of about 20-25% in terms of hospitalization of the combined endpoint, but cardiovascular mortality itself was not significant. So that led to some changes in the guidelines as well. So erythropoietin stimulating agents were not approved because the RED-HF trial was negative, but iron was already in the ACC/AHA and the ESC guidelines overall as a class 2A recommendation. But when these guidelines were written, not all the clinical trial results were out. So there was a class 2A recommendation for improvement in symptoms, exercise capacity, and a class 2B for the risk of heart failure hospitalization. But by the time all of these trials came out, the ESC guidelines were updated. We are awaiting an update from the ACC/AHA, HFSA guidelines. They're not updated yet, but the ESC guidelines recently were updated. And on the basis of multiple trials showing improvement in heart failure symptoms and quality of life, there was a class 1A recommendation given to intravenous iron supplementation. And on the basis of these other trials, there was a class 2A recommendation also given for reduction in the risk of heart failure hospitalization as well. So that leads us to the third trial, which is the HeartFit trial. This was the largest of the trial so far done with iron replacement, looking at clinical outcomes. Over 3,000 patients were randomized. So this trial had a primary endpoint, which is a hierarchical endpoint that looked at all-cause mortality, heart failure hospitalization, and improvement in 6-minute walk test. If you look at the all-cause mortality, that was 10.3% in the placebo versus 8.6% in favor of ferric carboxy maltose at 12 months. If you look at overall heart failure hospitalization, there were 270 fewer heart failure hospitalization at 12 months in favor of ferric carboxy maltose. And if you look at 6-minute walk test, the results were not as good as we have seen with other trials. It was trending in the right direction, but overall not as impressive as all the previous studies that I have shown you. If you look at the overall p-value, the p-value was targeted as less than 0.01. So again, perhaps we can discuss that a little bit more in the discussion section. But it was discussed with the regulators that because this will be the only large outcomes trial in US and not two trials, a threshold of p-value of 0.01 was set. That threshold was not met. So in a conventional sense, the p-value was significantly less than 0.05, 0.019, but it did not reach the threshold of less than 0.01. And the win ratio was 1.10 with a confidence interval 0.99 and 1.23. If you look at time to death or first heart failure hospitalization, again, in the right direction, but not as impressive as the previous meta-analysis that I've shown you, and time to cardiovascular death was not positive. So the question is, how do we reconcile all of these different results? If you look at the threshold analysis, which was pre-specified in terms of the 6-minute walk test of 10 or 20 meter improvement, those were both positive at 6 months and 12 months as well. So first thing is to put all the data together, and then two, try to sort of differentiate how to put all of these data together. So this was a meta-analysis now putting all the large clinical trial, confirm, affirm, and HeartFit together. One can see there was a statistically significant, about 14% reduction in the risk of total cardiovascular hospitalization or cardiovascular death. If you look at heart failure hospitalization, the p-value was 0.07. Again, more substantial results in confirm, affirm, and not as much in HeartFit, although going in the right direction, but not as significant. So these are all the meta-analyses of trials with ferric carboxy maltose. I'll show you some data with ferric maltose as well. But I think that this slide is worth spending 1 minute on because that really puts things in perspective. If you look carefully at what Dr. Panchad was presenting, iron deficiency is when your ferritin levels are less than 30. But we give a little bit of a pass that anything less than 100 is considered iron deficiency because it is considered that ferritin is a marker, inflammatory marker, and that it might go up in heart failure as a pro-inflammatory state. But we do require TSAT if your ferritin is between 100 and 300, right? We require the TSAT to be less than 20. But when it comes to ferritin less than 100, we have no TSAT requirement. So your TSAT could be 20, 25, 30, it could be. So now what the field is really struggling with, that if your ferritin is, say, between 50 and 100, so you don't have that absolute iron deficiency of ferritin less than 30, and if your TSAT is greater than 20, are you truly iron deficient? In other words, are we mixing people with both iron deficiency and those without iron deficiency with the criteria we are choosing? So the issue here is not the concept of iron deficiency associated with worse outcomes and multiple trials showing the benefit, but do you get this dilution of benefit because you're including some patients? And the first hint we get is right on this slide. If you look at the TSATs less than 15, 15 to 24, or greater than 24, one can see that if your TSATs are less than 20, you're definitely seeing the benefit. And if it's more than 20, you're not seeing benefit. And then if you look at by 15, 15 to 24, and greater than 24, if it's greater than 24, there's like just nothing going on. And when you put everything together, it all gets diluted out. And HeartFit trial had the highest proportion of patients with TSAT greater than 20 of all the trials that we have looked at. So that is one issue, is that are we getting dilution because of the higher proportion of patients that came in with TSATs of greater than 20. Another issue is what should be the replacement target, and most of the patients did not get iron replacement after 6 months to a year in this long-term trial, and that raises another issue of what should be the target of iron replacement therapy. So now if you put all of the trials together, confirm, affirm, HeartFit, and Ironman, so not only focus on ferric carboxymaltose, but ferric carboxymaltose and ferric diazomaltose, where we have trials, randomized controlled trials, one can see a consistent benefit in confirm, affirm, Ironman, but HeartFit is the one that has things going in the right direction, but not as strong as others. And that is the trial that had the highest proportion of patients with TSATs greater than 20. And that raises the question about the patient population versus the concept. Now, the FDA also has actually approved the iron replacement. So it's not only the guidelines that I showed you that gives an indication, but there is an FDA approval as well to treat iron deficiency in adult patients with heart failure and NYHA class 2-3 to improve exercise capacity. So this is summary that iron replacement is safe, and that if you put all the data together, there is a reduction in cardiovascular death or heart failure hospitalization. It's modest if you take out the HeartFit trial, or if you keep the HeartFit trial, but take out those patients with TSATs greater than 20, the results are pretty impressive and clinically relevant. Those patients with TSAT greater than 20, you do not see the benefit. So where does the field go now? Well, there's another European trial going on, FAIR-HF2, and we are really excited about FAIR-HF2 for a second reason, because it's actually conceptually really smart trial, because now they are not only looking at long-term clinical outcomes, but they have a much lower threshold for ongoing treatment. So their ongoing treatment is really not the usual iron repletion criteria, but more of sort of an iron toxicity criteria, that unless and until the ferritin is really high, regardless of other parameters, we will continue to replace. So that's a really interesting twist. We will learn more. And then there is an early phase trial in HFpEF going on as well. Everything that Dr. Pancharath and that I have said is really true for heart failure with reduced or preserved ejection fraction, although the FDA indication does not specifically say heart failure with reduced ejection fraction. We don't have the same data that we have in HFrEF in HFpEF patients. So at least the first step has been taken, and FAIR-HFpEF will give us some sort of an early look, and then the field will continue to evolve. So thank you very much for allowing me the opportunity to give you this perspective on outcomes with iron replacement.